So vasculitis is really multisystemic. So patients can come in with a whole wide array of clinical manifestations. And like all of our diseases, it's kind of putting together the pieces of the puzzle to try to make the diagnosis. Um, and the medicines that we use to try to control vasculitis are very strong often. So we don't want to just use them on a patient who has something else. And there are unfortunately a lot of different things that can mimic vasculitis. Partly you can differentiate some of them based on the type of vasculitis and what the classic mimics that would have similar clinical presentations could be. But you can have, malignancies that look like vasculitis, and a lot of different infections can look similar to vasculitis. And then there's also like different collagen vascular diseases, prothrombotic states. So many different sort of mimics exist that can be confusing with vasculitis. And often you'll have to go back if a patient's not responding to therapy to try to figure out if you've really made the right diagnosis. So I talk about some of that in my presentation. Um, in terms of how vasculitis presents, again, it depends kind of on the blood vessel size affected because you have inflammation of those specific blood vessels, and depending on where those blood vessels are supplying blood to, that's the tissue or organ system that would become damaged. So, for example, with some of the small vessel vasculitides like granulomatosis with polyangiitis, you can have skin manifestations, you can have pulmonary hemorrhage or cavitary nodules in your lungs. You can have renal involvement and a lot of, sinus destruction and inflammation. But some mimics for that disease would include things like, significant fungal infections in your sinuses or other bacterial infections. You can also have a lot of different types of infections that cause lung nodules. And many things can cause, pulmonary hemorrhage. So each disease has different potential mimics. Um, and there are some ways we use, biopsies to help us. Those can be really useful. Oftentimes, if somebody gets a biopsy and you're using treatment for that vasculitis and the person's still not doing well, you really still have to go back and maybe consider whether other tissue needs to be biopsied or go back and really root through some of their clinical history and presenting manifestations. So there are different clues in terms of the, vasculature involved, kind of the onset of presentation, other associated factors, again, depending kind of on which vasculitis you're talking about. I mean, one that I'll talk about in the presentation is, CNS vasculitis, and that's one that can be very scary for people to kind of manage and diagnose. And the treatment is for CNS vasculitis is usually using cyclophosphamide, which is a very strong immunosuppressive drug with a lot of potential side effects. Um, so other things like certain types of lymphoma can mimic a CNS vasculitis. Also, something like reversible cerebral vasoconstrictive syndrome, which is actually something that is reversible just with supportive management and doesn't require any sort of immunosuppression. So those are three different syndromes that are managed completely differently. And in that case, honestly, I really push really hard for a biopsy to really make the diagnosis. And even then, it's not always clear, but there are some clues in the blood work and in the CSF findings. But again, all of these people can come in with significant neurologic deficits. And so trying to tease out which one it is really will determine how you're going to treat them. And that's just one sort of example of a type of vasculitis that can have different presentations and ways to kind of differentiate and make sure that you're treating the right thing. But really the main take home for whether or not someone has a vasculitis or a mimic is what we do best, which is getting a good history, a really good physical exam, getting blood tests, getting radiology studies, getting biopsies, and trying to figure out exactly what's going on. But the take home would be that, especially if you are treating someone with a presumed vasculitis and they're not responding to your treatment, there's the potential that they have either refractory disease and you need to go up on immunosuppression. But it's always important to kind of step back and think about, is there something else potentially going on and am I missing the target? And do I need to reevaluate, what this person really might have, and kind of redirect your focus and redirect your therapy. So I think it's really about kind of being humble and stepping back and really questioning what exactly is going on, especially if a patient isn't doing well, and you're treating them for what you think is a vasculitis. There's definitely a lot of research going on in vasculitides and how to address, treatment regimens. There's also studies in terms of like biomarkers and, trying to figure out prognostically which patients are going to have what sort of disease course or need what sort of therapies. In terms of differentiating between vasculitis and some of its mimics, it really does come down to sort of your own history and exam, and then also kind of the strength of our tools that we have right now, whether that be, PET scans looking at large vessel inflammation and how we differentiate that from things like atherosclerotic disease, or other types of inflammation that can be picked up on PET scan, malignancies, things like that. So there are always kind of research and, you know, efforts to try to improve our diagnostics. But those take a long time to kind of develop and actually get to the point where they're clinically available for, everyday use. So just really that, vasculitis is super challenging, and people can come in with so many different sorts of presentations. So it can be a really major delay in making that diagnosis. But on the flip side, you really want to know what you're treating. And so there's always kind of a push and pull between, you know, treating for vasculitis, making that diagnosis, and kind of making sure you're really doing your due diligence of stepping back and thinking about things that we see maybe less commonly, like some of the collagen vascular diseases or malignancies or really rare infections. So I think it's all interesting and challenging, but difficult. And so just, keep an open mind, broaden the differential, and use everything that you have to try to make the diagnosis, whether that's your colleagues, imaging studies, biopsies. It's definitely a team sport, and so I think that's really the take home. There's been a real surge of interest and research in the vasculitis, so it's really an exciting time to kind of understand kind of the management options, the pathophysiology, the biomarkers, kind of how we're approaching disease, how aggressive we have to get these patients into remission. So there's just been a ton of interest in the field and research going on, which is fantastic. Because again, these diseases really can be life-threatening, and definitely quality of life-threatening. And so I think, I'm going to be focusing specifically on the ANCA vasculitides, which includes eosinophilic granulomatosis with polyangiitis, or EGPA, granulomatosis with polyangiitis, GPA, and MPA, microscopic polyangiitis. A lot of the clinical trials kind of lump together GPA and MPA, and then EGPA is kind of left off on the side, and there's separate trials that are looking at that. So there have been advancements in terms of therapeutic regimens in EGPA, and some of them hopefully will be approved soon for managing our patients. I think these are, again, rare diseases, so it's always good for people to have a refresher kind of on what medicines are available based on this clinical picture that a patient comes in with. Because, when a patient comes in with sort of non-severe findings, meaning not life or organ threatening, it doesn't mean that their quality of life isn't highly impacted. So really a lot of the research is around figuring out ways that we can manage these diseases and minimize the glucocorticoid burden. And then when it comes to the other vasculitides like GPA and MPA, there's been a lot looking into kind of the role of plasmapheresis, the role of different sort of rapid tapering glucocorticoid strategies, and whether we can keep our patients, get them into remission, keep them in remission longer, depending on what kind of strategy we're using. So those are all kind of things that we're looking at and have been researched more lately. I mean, I think from a diagnostic standpoint, we still don't have like one perfect blood test or one perfect imaging study that's going to say without a doubt this is what's going on. And so we're always working on refining our ability to make the diagnosis with better biomarkers, better prognostic clues, things like that. Um, And then, of course, the next step is which set of patients is going to respond to which type of treatment. And if we had some way to identify um, markers in an individual patient or features in an individual patient that would let us know that they're going to respond best to this specific therapy, that allows us to use that therapy without having to shuffle them through many other medicines that have other side effects that might not work. And then, of course, the longer term issue is the steroid toxicity, because we all know we use a lot of glucocorticoids up front, and our patients hate it, but it helps control their disease. And so, really trying to figure out, again, ways to get people off of glucocorticoids or minimize how much they're going to be exposed to, which decreases many of the miserable side effects from being on chronic prednisone and also the infectious risk. So I think because these are chronic diseases, even when we can get people into remission, um, the other thing that we always worry about is how do we predict when somebody's going to have a relapse? And is there any way for us to kind of get on top of it sooner so we can prevent major damage? So those are all kind of areas um, that are definitely challenging for clinicians, when they should really bite the bullet and escalate therapy or use more aggressive immunosuppression, um, or when they can maybe monitor and watch and are there tests available to kind of see if they might be able to not expose the patient to more steroids or more immunosuppression. Yeah, I think, in EGPA specifically, there has been uh, the medication mepolizumab was studied in the MIRA trial, and that's been approved for use in EGPA and has done a good job, especially in our non-severe patients, of getting people lower on their glucocorticoids. There's the mechanism of mepolizumab is that it targets IL-5, which plays a big role in kind of this Th2 pathway or eosinophilic pathway. Um, and so there have been other drugs under development, including benralizumab, which was presented at the ACR this year, and is probably going to be undergoing, attempts to be approved for FDA approval for treatment of this disease as well. We're borrowing a lot and learning a lot from our like pulmonary and allergy asthma colleagues, because they do treat a lot of eosinophilic diseases. And so I think hopefully as we learn from them and try some of their different medications, we might have more options for some of our patients. There's also been a smaller study, real world, looking at IL-4 blockade and EGPA. And so I think, we're learning more in terms of therapeutic targets and how we might be able to treat fresh patients, but also refractory patients who are not doing well on their current regimen. From the other side, the GPA MPA perspective, again, we have had a little bit larger studies with these patients, and there has been, a lot of interest in really trying to spare glucocorticoids. And so whether that be with, you know, using, depending on whether you want to use, plasmapheresis, whether you want to use rituximab, cyclophosphamide, how long do you put these patients on these medications? So there have been some advances in terms of, subsets of patients that might or might not do well with a specific therapeutic regimen. Um, there also, in the last few years was a drug approved to um, help reduce steroid burden in MPA and GPA, called avacopan, and so that medication has been increasingly used in the rheumatology community. So I think hopefully with time we'll be getting more real world data to see how effective that medication has been in terms of sparing glucocorticoids in our patients with new or relapsing disease. So again, new therapeutic targets, new therapeutic options are kind of being developed. And there are a couple of phase 2 trials that are out there right now, also looking at some of these diseases. And hopefully we'll have more options as we move forward. No, I think it'll be a great conference. It's always fun to talk about vasculitis because I love it, but it is challenging and it's something that gives people pause, but it's the more you kind of expose yourself to it and get comfortable managing some of the nuances, the more awesome it is for your patients and for you as a provider. I think it's always just really fun to meet with the colleagues there, hear their advances in all the other disease states, of course, and also just to kind of have that interesting discussion. What I like about this conference is that there's just a lot of back and forth and a lot of different uh, people who have had varying clinical experiences. And so it's always just really nice to have more voices at the table and kind of hear how people are approaching these diseases differently, and what we can learn from each other.